Good morning, good afternoon, and good evening, everyone. On behalf of Global Alliance for Medical Physics Education and Research, GAMPER, it is my great pleasure to welcome you to this international webinar on radiobiological aspects of radiotherapy and the potential for hypofractionation. My name is Abu Kausar, and I served as the director of GAMPER, and I'm honored to be your host for today's session. This event is made possible through the collaborative efforts of professionals across various regions, united by a shared vision to promote evidence-based radiotherapy practices, especially in diverse and resource-constrained settings. We are truly inspired by the tremendous support from the global to this event, with approximately 1,500 registered participants from 84 countries, representing 24 countries from Africa, 31 from Asia, 11 from Europe, 10 from North America, 5 from South America, and 3 from Oceania. Our audience today includes radiation oncologists, medical physicists, dosimetrists, radiobiologists, and clinical researchers, all committed to advancing cancer care through science and collaboration. Before we move to the main session, I would like to invite Mr. Zubairul Islam, founder and executive director of GAMPER, to deliver a brief presentation introducing the GAMPER.
Thank you, my dear colleagues.
And he's also a medical physicist and a radiation control officer at Labit Specialized Cancer Hospital, Dhaka, Bangladesh, and also serving as a current Secretary of Bangladesh Medical Physics Society. Mr. Zubairul, please.
Thank you, my dear colleagues. PPT is visible?
Yeah, can see you.
Thank you. It is a true pleasure to welcome you today as we explore the story and vision behind the GAMPER, the Global Alliance for Medical Physics Education and Research. Let's begin with who we are. GAMPER is a non-profit global initiative created to advance education, research, and innovation in medical physics. Our primary focus is in low and middle-income countries, where access to quality training and research opportunity in medical physics is often limited. We are led by a diverse team of young, enthusiastic international medical physicists, energized by the guidance of leading worldwide medical physicists and top radiation oncologists in the worldwide. So, why GAMPER was established? The motivation behind the GAMPER stems from the real-world gaps we have seen across the South Asia, Africa, and other LMICs countries. There is a serious shortage of trained professionals, and this compromises the treatment quality in patient safety. Global program don't always address the nuanced and local barriers. That's why first-hand experience of this. We built GAMPER from the ground up to respond directly to these underserved needs. And our work strongly aligns with the United Nations Sustainable Development Goals. In SDG 3 focuses on the good health and well-being. We contributed by expanding access to safe cancer treatment through skilled medical physicists. In SDG 4 highlights quality education. We support through standardized training and continuous learning. And SDG 17 promotes partnerships. We build powerful networks to foster innovation and collective impact. Our vision is simple yet bold. Empower medical physicists across the globe through education, research, and collaboration. Our mission spans 4 pillars: education, training, collaborative research, mentorships, and human resource development, and global partnership. And already we have initiated some projects. So in our ongoing projects, first of all, the collaborative research programs. This marks GAMPER first global research collaboration, bringing together researchers from 22 countries. Each team will work on diverse topics relevant to their region, guided by top mentors in medical physics and oncology. So, what is the outcome? The findings will be published in reputed peer-reviewed journals. This initiative is open to medical physicists, radiation oncologists, and early career researchers. Participation calls will be circulated, but everyone interested can also reach out directly to the GAMPER team to get involved. Our another ongoing program is the educational series. Our ongoing webinar series brings world-class knowledge to local clinics. These are more than just lecture. They're interactive forms grounded in real clinic needs across the LMICs. Expert cover advanced in imaging, radiotherapy, in nuclear medicine, make sure learning in practical, immediately applicable. And in our upcoming programs, looking ahead, we have introduced robust lineup in accredited program, master class, hands-on clinical training, scientific paper writing, and research method workshops. And another one is the mentor-mentee program and virtual school of medical physics. So, none of this possible without this people. This is my team member, and this our honorable advisory council member. Without their support and guidance, it could not possible to it happen. They bring academic rigor and clinical excellence and professions for shaping the future. And in my concluded session, as I want to share a quote, as Helen Keller said, "Alone we can do so little, together we can do so much." Thank you for being part of this journey to connect minds and transform medical physics around the world. Thank you.
Thank you, Mr. Zubairul, for your presentation. We will now proceed to the scientific session, which will be moderated by Mr. Abdul Sattar Khalid. He is a senior medical physicist, proton beam therapy at the Christie NHS Foundation Trust, Manchester, United Kingdom. Mr. Khalid, the virtual floor is yours.
Thank you for the introduction, Kausa. Welcome everyone to this first webinar, hopefully in a series of many to come. So I will be moderating the session today, and we have a great presentation here by Professor Colin Orton, who, as you will all know, is a professor at Wayne State University in the United States of America, an internationally renowned medical physicist with over 6 decades of academic, clinical, and professional leadership in radiation physics and radiotherapy. He will be presenting to us today radiobiological aspects of radiotherapy and the potential for hypofractionation. And followed by this session, we will have a panel discussion by Dr. Dodal Mondal and Professor Savino.
Sorry for interruptions, Mr. Khalid Bhai.
Yeah.
Your PPT is not visible.
I don't have a PowerPoint. I'm just going to talk this through.
Okay.
Thank
Please
you.
carry.
Yeah, sure. So the panel discussion will follow the talk after Professor Orton has done his talk. So what I advise the audience to do is please write your questions into the chat box, and the team, myself, Abu Kausar and Jabarul, will try to put them together, and we can go through the questions at the end of the talk. I'll introduce the panel members after the talk. So without further ado, I will pass the floor over to Professor Orton to start his presentation.
Well, thank you very much, Abdul. Right now, I don't think I'm able to share my screen, so maybe somebody can give me permission to share my screen. We did it earlier in this before the session started, but now I click on share screen and I'm not given permission. No. Okay, we got it. I've got it. Thank you. I've got share screen now, so hopefully I can share my screen. Okay, hopefully everyone can see that. Can you see that?
No, we cannot see that. We cannot see your screen.
Okay, then we'll start again. Sharing my screen. Okay, share my screen. Okay. I'm clicking on share.
There we go. I think it's loading now, Colin.
Yes.
Okay. How about now?
Yeah, that's okay.
Great. Everybody see that?
Yes, we can see you.
Excellent. Okay. Well, this is a topic that I've always been interested in. I was actually thrown in the deep end the very first day I started work. When I arrived in America from England, my very first job, I'm sitting at my desk, and in walks the chairman of the department and said, "Colin, I'm having trouble with understanding these mathematical models that are being published that compare different fractionation schemes. Can you help me?" And that was it. From then on, I became a so-called expert in mathematical modeling for radiotherapy of cancer. And ever since then, I've been giving lectures on this, and it's been I've always considered it my hobby. I'm paid as a physicist, but my hobby is radiation biology modeling. So let me start by saying I'm going to talk about fractionation. But why did we ever fractionate? Why didn't we just simply go, if we knew that radiation, or we thought the radiation cured cancer, why didn't we just go in and give a big dose of radiation to the cancer? Well, there were lots of reasons why we didn't do that. And let me just go back very briefly into the history of fractionated radiotherapy. The very first documented successful treatment of a patient was this lady who you can see has a basal cell carcinoma on her nose. This was a lady in Sweden, and she was treated. And she was treated in 1899, and this is the result 30 years later. She's cured of her cancer, so it's a documented curative case right after the discovery of X-rays. The reason I'm showing you this slide really is this fractionation scheme. This patient, believe it or not, had 99 fractions. So amazing. Why 99 fractions? What was going on? Well, there were lots of reasons for that. The main reason is that the output of the X-ray unit she was being treated on was extremely low. So in order to complete the treatment in one fraction would have taken literally days. And the way they used to do their therapy in those days was they used the skin reaction on the patient to tell them what dose they've given. We called it the erythema, not we, but they called it the erythema dose. And this was before they had dosimeters. And once the patient reached tolerance, they reached a skin reaction that was no longer going to be tolerable, they stopped the treatment. So the way they did these treatments, you just kept giving a fraction, maybe 10, 15, 20 minutes each day. Patient would come back the next day. we could give more, another fraction. And this particular patient presumably went to 99 fractions before she reached skin tolerance. The other reason that doses had to be fractionated is that the dose each day was totally unpredictable. You had no idea, because of the poor quality of the X-ray units in those days, you didn't know what dose you gave. You gave maybe 15 minutes of treatment, but you didn't know how much radiation was coming out of the equipment. You only found out what dose had been delivered after the completion of each session if you put some kind of dosimeter on the patient's skin. Clearly, you couldn't give the full treatment in a single unpredictable fraction. Not long after the discovery of X-rays, a method of dosimetry was developed, but basically film dosimetry. You put a piece of silver bromide film on the patient's skin. We're treating this patient's knee here, and the blackening on the film told you how much dose the patient had received. So you put the patient, here we go. The blackening was a measure of the dose. So let me show you a typical treatment chart of a patient just to show how variable the treatments were each day. Here's a treatment chart of a patient, and this is the blackening on the film each day. So you see the first 2 days of treatment, it was too black, couldn't be measured. And then from then on, sometimes it became very light. There wasn't much dose that day. And then other days there was more dose. You had no idea what dose you were giving each day because of the equipment. It just wasn't able to give you a constant dose each day. This all changed with the invention of the hot cathode X-ray unit in 1914 by William Coolidge. Then dose rates became higher, much higher, so you could go to very high doses, and they were reproducible each day. And that's the equipment that we use now, the hot cathode X-ray tube. After this, there were two schools of thought about fractionation. There was one school of thought that I mentioned earlier, that you could give the whole of the course of radiotherapy in a single fraction. Now you've got a high enough output, you could do that. And some schools, for instance, in Germany, the Germans decided that a single fraction was essential for the treatment of the patient. Alternatively, in France, in Paris, they decided only with multiple fractions can you cure cancer without exceeding normal tissue tolerance. Let's look at the single fraction school. They believed that fractionated treatments were inferior because they allowed cancer cells to proliferate during the course of treatment. So the cancer cells kept repopulating while you're trying to treat them, get all the radiation in quickly, and then they don't have a chance to repopulate. To overcome this would require higher doses be delivered, and these would not be tolerated by the normal tissues. So they weren't actually curing their patients because they couldn't go to a high enough dose to cure the patients. They got to their so-called tolerable skin dose, for instance, and they hadn't given enough dose to cure the patients. Then there was a multiple fraction school in Paris. They believed that you had to give dose fractionated or you couldn't cure tumors without exceeding normal tissue tolerance. It wasn't until 1932 when Coutard in Paris published his excellent results with fractionated therapy that the world realized that fractionation was essential. And then from then on, everybody fractionated their treatments. Well, do we know now radiobiologically why fractionation is so important? We didn't know then. We just knew by clinical practice that fractionation was important. But what do we know about it now? Yes, we do. It's because cells are able to repair radiation damage when low doses or low doses per fraction are used. So this is what we now call repair. Cells are able to repair the damage as long as you haven't gone to a high enough dose to prevent the cells from repairing. So let's look at the DNA molecule to see what we mean by this. And there are two types of interactions in the DNA molecule. there are single strand breaks shown in this upper diagram here. And these are usually considered repairable. What do we mean by repair? Well, the two arms of the DNA carry identical information. So this arm carries the information that's been destroyed by the interaction. This would be, say, an electron interacting and damaging this arm of the DNA. This arm of the DNA has the information that's been destroyed here, and there are repair enzymes within the cell that will copy this good information and repair, using that good information, repair that DNA strand. That's obviously a simplified description of what's going on. On the other hand, there are double strand breaks in the lower figure where two separate strand breaks, or it might actually be a single particle going across both arms of the DNA, damaging both arms of the DNA close together, opposite. So now, if these two damages are there at the same time, you can't repair. There's no repair can take place because the biological information, the genetic information, is no longer available to do the repair. So what's the effective dose? Well, at low doses, both DNA strands are unlikely to be hit at the same time, particularly if you allow enough time for that repair to take place. And we'll talk about that in a second. So single strand breaks would dominate and repair is common. At low doses, repair is common. At high doses, on the other hand, there's a higher probability that both arms are going to be damaged at the same time. Particularly, again, if you give that radiation quickly enough that the first strand hasn't had time to repair before the second strand gets damaged. And so there will be little repair at high doses. So consequently, if you plot the survival of cells, they get steeper as the dose increases. They're not steep at low doses because you get repair. They become steeper at high doses because you can't get so much repair. So here's a cell survival curve, plotting log survival against dose, and you see it's fairly shallow at low doses, but it becomes steeper at high doses. Low doses are mainly repaired, high doses are not repairable. So now let's compare survival curves of normal cells and cancer cells and see if they're different. And sure enough, they are. We find that cancer cells do not repair damage at low doses as well as do normal tissue cells. They've actually damaged their ability to repair cell damage. Survival curves will be straighter. There is a window of opportunity at low doses where the survival of late reacting normal tissue cells that are going to cause complications exceeds that of cancer cells. Let's look at that. Here we are. Now we've got this cell surviving fraction curve. We've got the cancer cells in red and the late reacting normal tissue cells in green. The green curve is curvier because you've got more repair, whereas the cancer cells are less curvy because you have less repair. So at low doses, survival of normal tissue cells, the green curve, exceeds that of cancer cells. At high doses, survival, the red curve, exceeds that of normal tissue. So what you want to do is work within this region where you get a higher survival of the normal cells than you do of the cancer cells. And this is why we fractionate at low doses per fraction. We need to fractionate it doses per fraction within this window of opportunity. For the parameters that I use to generate the curves that I just showed you, this is typically about 2 gray per fraction. So these are the two curves I just showed you, the bottom two curves here. And this is what happens if you fractionate at 2 gray per fraction. What you find is that the normal cells start surviving considerably more than the cancer cells, the blue curve here. And if you're going to go out to about 60 gray, for example, at 2 gray per fraction, these will be several orders of magnitude separated, and you'll get 100 or more times the cell survival of normal cells compared to the cell survival with tumor cells. So that's why we fractionate, and that's why we've been fractionating at about 2 gray per fraction for all these years. So there's a window of opportunity here. What I've just showed you assumed that the x-axis was just dose. I was giving the same dose to the normal tissues to generate those curves as I was giving to the cancer cells. But is this a reasonable assumption nowadays when we're doing highly conformal teletherapy? Didn't used to be. For many, many decades, we weren't able to do highly conformal radiotherapy. We didn't have things like multi-leaf collimators, and we didn't even have rotation on most of these units, isocentric machines. But of course, we now have highly conformal therapy. Is this a reasonable assumption? Well, no, of course it's not. It's because the major advantage of conformal radiotherapy is that the dose to the normal tissues is kept less than the dose to the tumor. It's the, let's call it effective dose. The effective dose to normal tissues. Well, remember, these dose distributions are not uniform. There are dose distributions within the normal tissues and dose distributions within the tumor. If we can define an effective dose, the effective dose to the normal tissues will usually be less than the effective dose to tumor if we have highly conformal radiotherapy. We can define effective dose in lots of ways. Today, we would define it as the equivalent uniform dose, or EUD. So your treatment planning computers nowadays will be able to calculate EUDs for the normal tissues, for each normal tissue or organs, and for tumors. And now we can define a geometrical sparing factor. We can define this. It is the effective dose to normal tissue divided by the effective dose to tumor. And for highly conformal radiotherapy, this will be less than 1 and probably much less than 1. So what does that do to those two curves that we've been looking at? Well, here's the cancer cell curve. And now the normal tissue, late reacting normal tissue curve that's going to be responsible for complications has moved to the right 20%, because I'm assuming a very modest geometrical sparing factor of 0.8. So just a 20% varying of the effective dose to the normal tissue. Look what happens. What happens is that this window of opportunity has now grown significantly. Instead of being wide open at 2 gray per fraction, it's now wide open at much higher doses per fraction. So what does this mean? Well, it means that with highly conformal therapy, we can safely use higher doses per fraction. Teletherapy means hypofractionation. For brachytherapy, it means the use of high dose rate. So we have high dose rate brachytherapy. What about dose rate, and what about time between fractions? We haven't mentioned that yet. Well, repair takes time. The half time for a typical repair of cells is about half to 1.5 hours. So repair decreases as the time between fractions decreases, and as the dose rate increases. We're going to get too much radiation in too quickly before the repair has had time to take place. So what is the importance of time between fractions? Because repair is more important for normal tissues than for tumor, repair does take place in tumors, but not as effectively. We want to take maximum advantage in radiotherapy of the repair of the normal tissues being better than repair of the tumors. So it must leave enough time between fractions for full repair. It turns out, and I'll show you the data on this later on, that from clinical results, we've discovered that this needs to be at least about 6 hours between fractions. So if we're giving multiple fractions per day, we should leave at least 6 hours between fractions. What about dose rate? Normal tissue cells repair better than cancer cells. A low dose rate enhances repair. This is the basis of low dose rate brachytherapy, and especially permanent implants of very low dose rate. Now, what about the overall treatment time? We haven't mentioned that. We've talked about cancers repopulating during the course of therapy. Well, let's look at that. Cancer cells, and by the way, your cells of acutely reacting normal tissues, proliferate during the course of therapy. It's called repopulation. Cells of late reacting normal tissue cells don't proliferate much at all. Hence, the shorter the overall treatment time, the better as far as cancer cells are concerned. On the other hand, you've got to be careful of doing that because you might exceed the tolerance of the acute responding normal tissues like skin and the mucous membrane in the mouth and so on. So you've got to be careful. You can't accelerate the treatment so much that the acute reactions start causing significant problems in the patient. Very uncomfortable for the patient, and you can actually exceed the tolerance, and patient can actually die from the acute reactions if you're not careful. So how does all this affect the way we treat cancers? Well, we can use different types of fractionation, and we can use different dose rates for brachytherapy. So let's look at different fractionation schemes that we've tried over the years in an attempt to improve the way we treat cancer. We started out with conventional fractionation, and then we tried for many years to use hypofractionation, where you use many more fractions, presumably at a lower dose per fraction. And then we tried accelerated fractionation, getting all the radiation in quicker to see if that makes a difference. We tried a mixture of these two, taking the advantages of hypofractionated radiation and accelerated fractionation. We call that hypofractionated accelerated fractionation. And then we've tried, and we're much more recently endeavoring to use hypofractionation. I'll come back to that at the very end. So let's look at conventional fractionation. What have we used over the years that seems to work very well? Conventional fractionation, typically the dose per fraction is varied between about 1.8 and 2.2 gray. Typically, we'll give 5 fractions a week. If we really wanted to accelerate it, we could try giving 7 fractions a week. And in my department, we tried that. It became very unpopular with our staff because they had to come in at weekends, and we dropped that very quickly because it didn't seem to show a significant advantage. Total dose anywhere depending on the cancer. If it's a fairly sensitive cancer, 50 gray would be enough. If it's a fairly resistant cancer, maybe 65 gray, or maybe even as high as 70 gray might be enough. And it was being used for most patients in the past. So probably if you go back in history, 95% of all patients have had conventional fractionation. Well, what are the problems of conventional fractionation? Well, it may be too slow for the treatment of fast-growing cancers. So a cancer that's growing too fast, you're giving this treatment over maybe 5 or 6 weeks. Maybe the cancer's growing too fast and it's growing faster than you can treat it. So there's a problem. The total dose may be too low for some resistant cancers. Maybe 65 gray isn't enough, and you need to go to maybe 75 or 80 gray for some resistant cancers. We can go to higher doses without exceeding normal tissue tolerance by giving a lower dose per fraction. And this led us to try doing hyperfractionation. We could go to a higher dose by giving a lower dose per fraction, allowing the normal tissues that are going to cause complications more ability to repair the damage. The lower the dose per fraction, the more ability those cells are going to have to repair the damage. So typically what we used was 1.1 to 1.3 gray per fraction, typically 10 fractions a week. Okay, bad news. That means you're treating 2 fractions every day. Otherwise, the overall time will be too great and the cancer cells will have too much time to repopulate. So you want to get all the radiation in about the same time, but you're going to a higher total dose. So typically we could go to 70 to 80 gray with hypofractionation. And it's used when late normal tissue tolerance is a major problem and you can't go to a high enough dose to cure these resistant cancers. And this was tried for many years in clinical trials all over the world. But there are clearly problems with hypofractionation. 2 fractions a day with at least 6 hours between each treatment puts extra burden on the patients, the staff, and the equipment. Patients have to hang around all day, pretty much. You could only treat half as many patients on the equipment because you're treating each patient twice each day. And so it's much more expensive to do. And then after many, many clinical trials over decades, there was no clear benefit demonstrated. So hypofractionation is rarely used today. But we tried. There was also an attempt to accelerate fractionation for rapid growing cancers. This could be achieved by either using 2 fractions a day or a higher dose per fraction. If you're using 2 fractions a day, you want to give more than 1 to 1.3 gray per fraction, the way we did with hypofractionation. You maybe want to go quite a bit higher than that. So typically what was done was to go to about 1.4 gray per fraction, 2 fractions a day, or you increase the dose per fraction to maybe as high as 2.5 gray. And then the fractions per week, depending on which scheme you're using. If you're using a higher dose per fraction, you give 5 fractions a week. A lower dose per fraction, like 1.4 gray, you'd have to give 10 fractions a week. So they're totally dose depending on which way you were doing it. But notice these doses are much lower than we were using before. So you don't want to use this for highly resistant cancers, but you do want it to use it for cancers that are rapidly repopulating while you're trying to treat them. Well, what are the problems with accelerated fractionation? Well, early responding normal tissues that we mentioned earlier may not have time to repopulate in the 3 to 4 week course, so acute reactions have been a major problem. And in fact, if you look at the clinical trials that were done, quite often you had to give the patient a couple of weeks rest during the course of treatment. And of course, that totally negates the acceleration of the treatment. Instead of doing the whole treatment in 4 weeks, you're back to 6 weeks because you've had to give the patient a rest. So that wasn't very good. And in fact, there was no clear demonstrated in clinical trials over the years. And that kind of died away. We're coming back to it later on, as I'll show you, when we're doing hypofractionation. But there was no clear benefit using daily fractionations of this order of magnitude. One of the problems was what became known as the Withers hockey stick. Here's all of these points here represent a clinical trial. Every single point represents a clinical trial of head and neck cancers treated with radiation to different doses and with different overall treatment times. So some of these clinical trials were done with 10 days overall treatment time. Some of them were done with 60 days overall treatment time. And you got this thing that was called the Withers hockey stick. Rod Withers from the MD Anderson Hospital in Texas plotted this, and he said, look, what happens is after about 3 weeks of treatment, suddenly you're going to have to get to much higher doses because the cancer cells have suddenly realized that you're trying to kill them, so they repopulate faster. So this is called accelerated repopulation. There have been other publications using the same data that showed, in fact, that you could just as well statistically draw a straight line through this. Because look at all the big error bars. You could just as accurately draw a straight line through all this, and there was no accelerated treatment repopulation. There was just repopulation. Personally, I kind of tended to believe that. In fact, there was an AAPM publication by the Biological Effects Committee of AAPM that demonstrated that it was equally statistically proven that you could draw a straight line through these, and there was no acceleration of the treatment. So I've tended to ignore accelerated repopulation. But at the time when this was published, people try to get the radiation in quicker. The quicker you can get it in, the better. So how could you do that? Well, they in the UK, they invented a scheme called continuous hypofractionated accelerated radiation therapy, taking advantage of hypofractionation at low dose of perfraction and accelerating it. This was called CHART. And the way it was done was to use 1.5 gray per fraction, 3 fractions per day, believe it or not. So it really very intensive treatment. 6 hours between fractions, by the way, because they tried not using 6 hours between fractions because it's very inconvenient to use 6 hours between fractions. And they found they got terrible late reactions. The total dose was 54 gray. It was used for rapidly growing cancers, typically head and neck cancers and lung cancers. It was used for many decades. They were trying to demonstrate that this gave better clinical results. The treatment was all completed in 12 days. We've been talking about acute reactions. This would be terribly bad for acute reactions because you're not letting the acute reacting tissue much time to repopulate. Well, it turns out that the acute reactions don't peak until after the end of the therapies. So the acute reactions that we mentioned before with accelerated fractionation took place after about 2 or 3 weeks of treatment. And then the patient got terrible acute reactions, but you'd finish treatment, you send them home, or you hospitalize them to look after their terrible acute reactions. This was very inconvenient since you had to treat 12 consecutive days, including weekends. So another scheme was devised, which was weekend-less, chart well. So you only treated 5 days a week instead of 7 days a week. But basically, you kept it the same. The dose was the same, but now you're in 16 days, and the acute reactions peaked after the completion of treatment, but it would be close. The patients really start to get terrible acute reactions just before the end of this treatment. So what were the potential problems of chart and chart well? Well, initially, several patients were treated, as I mentioned before, with less than 6 hours between fractions. This is how we learned that you needed 6 hours between fractions. Late complication rates were excessive with these short interfraction times, and they were abandoned. A strict minimum of 6 hours between treatments had to be mandated. This made these treatments highly inconvenient, putting a very great burden on patients, staff, and equipment, and of course, making them much more expensive because each patient was treated 3 times each day. You're treating a third as many patients on each machine. Acute reactions have been a major concern with these patients. Most patients had to be hospitalized as soon as they completed therapy for the treatment of excessive acute reactions. In fact, many patients died of their acute reactions, which obviously wasn't a good thing to happen. Results of clinical trials have not been all that promising. So it's very inconvenient, very expensive, and very hard on the patients because they get very quick reactions. So pretty much techniques have been abandoned. They didn't really work. There's probably a few places still doing it. Let's now spend the rest of my time talking about hypofractionation. So what do we mean by hypofractionation? The use of fewer fractions at higher dose per fraction. Doses per fraction, depending on how many fractions you're going to use, vary anywhere between 3 and 20 gray, and the fraction numbers anywhere between 1. If you're giving 20 gray, you're going to give 1 fraction, or if you give 3 gray per fraction, you're going to give 20 fractions. Well, what are the problems of hypofractionation? Well, historically, because of the risk of late complications, the total dose was kept considerably less than that needed to cure cancers, and hypofractionation was used for palliation only. For many, many decades, we didn't have conformal radiotherapy. We didn't have rotational machines. We didn't have stereotactic radiosurgery and all those kind of nice things that we have now, like multi-leaf collimator. Just didn't have that. So the dose to the normal tissues were almost the same dose as the dose to the tumor. And the geometrical sparing factor would be 1. However, it's now being used to cure with highly conformal therapy. So what do we know? Well, clinical trials around the world are beginning to show that with highly conformal therapy, hypofractionation can be used just as effective as conventional fractionation, both for cure and avoidance of normal tissue complications. But we already knew this actually for many decades, since the mid-1960s with the gamma knife. We knew that you could give a single dose of stereotactic radiosurgery in the brain and cure cancers in the brain without too much normal tissue damage. So we knew it could be done, but with highly conformal radiotherapy, such as with stereotactic radiosurgery. So my prediction is that with even more confirmation of dose distribution using more sophisticated imaging, image guidance, motion tracking, etc., we'll be using as few as 10 fractions for most cancer in the near future. Treatments will cost less. You're giving fewer treatments, you can treat more patients. Accelerated regimes will now be more prevalent, thus reducing cancer cell proliferation during treatment. So for rapidly growing cancers, you can accelerate the treatment as long as you have a highly conformal dose distribution. And I predict the cure rates will actually increase by doing hypofractionation. Well, how can we determine the best fractionation to use for our patients? What we need is a mathematical model that describes the effects of radiotherapy on cancer and normal tissue cells. And we do have that. It's called the linear quadratic model. So let me just spend a little time talking about the linear quadratic model. The linear quadratic model, there are 2 components. We talked about these earlier on when we talked about the irradiation of the DNA molecule. We said there's a linear component, double strand break caused by the passage of a single charged particle, an electron or a proton if you're using proton therapy, or heavy ion if you're using heavy ion therapy. And these will be the slow electrons, the secondary electrons that are produced from our X-ray therapy, or it might be a beam of electrons if you're doing electron therapy. So that just passes, zips right through, causes damage to both arms of the DNA at the same time. And then there's this quadratic component where there are 2 separate single strand breaks caused by different charged particles. And as long as there's enough time between those 2 single strand breaks for repair, then that damage can be repaired. So what does that look like in terms of the cell survival curves that we've been talking about? Well, here's the single strand break caused by an ionizing particle, this here, a low energy electron that just goes through and damages both adjacent arms of the DNA molecule, no repair. So this is linear. Then you get the curvier cell survival curve due to repair because you've got 2 separate interactions, and there may be enough time between these interactions for repair, particularly if you're fractionating the course of radiotherapy. There's time to repair. Well, what about how is this a function of dose? Well, if I double the dose, I'll double the number of these types of interactions. So it's a linear function of dose. On the other hand, down here, this interaction is a linear function of dose. So the probability that this interaction occurs is a linear function of dose. The probability that this other interaction occurs in the other arm of the DNA is also a linear function of dose. And probabilities multiply. So the effect is quadratic in dose. So you get a linear quadratic curve. And what's the equation for that curve? Well, log surviving fraction is a linear function of dose, and a quadratic functional dose. Alpha represents the probability of an alpha type. We call it an alpha type damage. A beta represents the probability of what we call the beta type damage. What are the problems with this LQ model? Well, there are too many unknown biological parameters, in this case alpha and beta, for reliable values to be determined from analysis of clinical data. What we'd like to do is to go to years of clinical experience, lots of data. I'll go back to that later on and show how we're doing that. Lots of data. Now we have to determine the best fit parameters, alpha and beta. That's not easy to do. But this can easily be reduced to one parameter by dividing log surviving fraction by this parameter alpha. So let's see how we do that. This is the equation we showed before, the linear quadratic model. Let's divide both sides by alpha. Well, if you've got n fractions, each fraction you get this occurring. And then if you divide by log surviving fraction by alpha, you get this equation. And now there's only one unknown parameter. It's alpha over beta. Alpha over beta is the tissue or organ or tumor biological parameter that represents the repair or lack of repair of these cells. So what are the typical values of alpha over beta that we can use if we're going to do some calculations of fractionation? Well, for tumors and acute reacting tissues, most of the time we can use something like 10 gray, whereas for late reacting normal tissues where there's lots more repair, so beta is bigger than alpha, it's a smaller number, 2 to 3 gray. So typically if I'm doing calculations to try to maybe modify a fractionation scheme, I'll typically use 10 gray for tumor and 2 to 3 gray for normal tissues. But there are exceptions, and we're beginning to see clinical trials that demonstrate that there are some significant exceptions. Prostate cancer, for instance, the cancers may be as low as 1.5 gray instead of 10 gray. That means they're very good at repairing damage. Breast cancer cells also a little bit lower than, quite a lot bit lower than the 10 gray, about 4 gray. So they're good at repairing. So we need to design our treatment schemes based on that fact that we know these values because we've got lots of clinical experience. And I'll show you some really good publications on how we've determined these values for alpha over beta for different cancers. What about repopulation? We haven't talked about repopulation yet. The BED equation for repopulation is the normal BED equation with alpha over beta minus you lose effect due to repopulation, and it's a linear function of time. So, and this is ignoring accelerated repopulation. I'm just saying, let's assume that the cells are constantly repopulation. They don't decide to accelerate. You could put an accelerated repopulation term in here. I don't do that because that would be another unknown parameter. Now I've got two unknown parameters. I've got alpha over beta and K. If I assumed accelerated repopulation, I'd have a third parameter in here, which would be unknown. So I've got to determine alpha over beta and K from analyzing lots and lots of clinical data. Typical values of K that I assume for normal tissues, I assume for acutely responding normal tissues, if I want to do that calculation, somewhere between 0.2 and 0.3 BED units every day. Late responding tissues, some people say they respond a little bit. You get some repopulation of these tissues. I assume 0 most of the time for late responding normal tissues. Note that this is not gray per day. You see that in the literature a lot of times they just call this gray per day. It's not gray per day because BED is a linear quadratic function. It's not dose. It's not gray per day. It's BED units per day. And what about for tumors? Typically, I will use for slow growing cancers about 0.1 BED units per day. For average cancers, about 0.3, and for rapidly growing, calculate what I need to do, what total dose do I have to do with this particular type of treatment. First thing I'll ask him, how rapidly is the cancer growing? And he'll tell me, and most of the time he'll wave his arms and say, I don't really know, let's assume it's an average cancer, and I'll use 0.3. But sometimes he'll tell me it's a rapidly growing cancer, which is why I'm planning to change the way I'm treating these patients. So let me show an example of how I would use this for a course of radiotherapy. I'm changing the course of radiotherapy, and the radiation oncologist comes to my office and said, I don't want to give the usual conventional treatment. I want to give all the treatment in 10 fractions. So it's required to change a conventional fractionation scheme of 60 gray delivered in a 2 gray per fraction over 42 days to hypofractionation with 10 fractions. We're going to allow weekends, 10 fractions deliver over 14 days. How do I do that? How do I calculate what dose to give with this new, what dose per fraction should I give with this new scheme? And by the way, while we're doing it, am I going to have an increased effect or a decreased effect on late reacting normal tissue cells? Clearly, what I want is to have less effect on late reacting normal tissues. And then there'll be an advantage for this particular patient. So let's make some assumptions. Let's assume a 0.6 geometrical sparing factors. We're using highly conformal therapy for this patient. And let's assume that it's an average repopulation of about 0.3 gray per day. Let's look at the tumor BED for 30 fractions of 2 gray. Simply, we just take 30 fractions, 2 divided by 10. I'm assuming the alpha over beta is 10. I'm going to subtract this because it's repopulating at the rate of 0.3 BED units per day. So the BED for tumor with conventional scheme is 55.2. So let's now devise the 10 fraction scheme to get to this same BED. So we're equating this BED of 55.2 in 10 fractions of unknown dose per fraction, and it's over 14 days, so 0.3 times 14 days. And this is a quadratic equation. Just need to solve the quadratic equation, and lo and behold, I find I need to give 10 fractions of 4.26 gray for this patient. Solve that problem. But now, what's the effect on late reactions? Okay, so we now need to look at the BED for late reactions. Well, the dose to normal tissues, they're being spared by a geometrical sparing factor of 0.6. So the dose for normal tissue treatments will be 30 fractions of, this is with the hypofractionated treatment that we're using now, 4.26 times 0.6, 2.56 gray in 10 fractions treatment. Then the BED for normal tissues will be BED for normal tissues. I'm assuming an alpha over beta of 3 at 1.2 gray per fraction. The BED for normal tissues will be 50. But it's only if I'm now, instead of just giving 2 gray per fraction with 0.6, 2 times 0.6 is 1.2. This would be the normal conventional treatment gives me a BED of 50, whereas the hypofractionated treatment gives me a BED of 47. Lo and behold, it appears that the 10 fraction schemes is now somewhat less damaging than normal tissues. Very small difference, but wonderful. It's possible that we're actually going to be able to get less normal tissue damage for the same. We may be even able to go to a slightly higher total dose to increase our probability of curing the cancer. So what does all this mean? It means decreasing the number of fractions, example for example, hypofractionation, does not necessarily mean increasing the risk of normal tissue damage. Use the LQ model to demonstrate what I've been saying all along, that maybe hypofractionation could be better than conventional fractionation. Of course, all these calculations depend on the parameters we use. But do we know what parameters to use? What alpha over beta to use? What repopulation rate to use, for example? Well, yes, we kind of do know what parameters to use. At least we're close to knowing that for normal tissues due to what's called the Quantec initiatives that were stimulated by the AAPM in 2006. This is the quantitative analyses of human tissue effects in the clinic. We developed very large databases of clinical data, dose distribution data from clinical trials, and then evaluated all this data to look and see how well models fit and what are the parameters of those models that best fit the data. And then publication of the best fit models and parameters, I'll show you that in a moment. And we're just beginning to analyze tumor control probability data. What are the parameters that we need to use for different types of tumors? And there was a whole issue of the Red Journal published in May of 2021, 4 years ago. Here we go. It was called Hypofractionated Treatment Effects in the Clinic, or HYTEC, H-Y-T-E-C, HYTEC. And you can actually get this for free. If you go to the Red Journal website and look for May 2025, you'll see that you can download the whole of this journal, all of the articles in that journal for free. And there's some excellent articles that deal with the biological modeling of normal tissues and tumors, TCPs and normal tissue complication probabilities. So let me summarize my presentation. We fractionate because late reacting normal tissue cells repair better than tumor cells at low dose superfraction, which I call the window of opportunity. With highly conformal therapy, we can treat at higher dose superfraction because the window of opportunity widens. And in the future, we are likely to increasingly use hypofractionation. As if you look at that Red Journal from 4 years ago, you'll see many articles published looking at a variety of clinical trials that have been done with hypofractionation, showing that indeed it does work and you can get very good results. Well, thank you all for listening, and hopefully you've gained something out of my presentation.
Thank you very much, Colin, for an excellent presentation. That was an excellent journey through radiobiology from the beginning, and it was very, very easy to follow and understand such complicated steps of radiobiology in radiotherapy. And thank you for explaining hypofractionation and how that could help in the future. I'm one of the same kind of understanding. I believe hypofractionation is the way forward, especially with being able to treat more patients in such a short time and limited resources. I think that's an excellent thing for the LMIC countries that we're sort of approaching mostly. So thank you very much. I think I'll introduce the panel discussion now, and then we'll collate the questions together for Colin, and we'll present those questions to you, Colin, and you can help answer them later. Thank you. So the panel discussion is going to be held by Dr. Dodul Mondal, who's a radiation oncologist, director and head of the Department of Radiation Oncology at the Max Super Speciality Hospital in New Delhi, in India. He's a distinguished clinical oncologist specializing in high-precision radiation techniques, and that includes proton beam therapy, SRS, SBRT, IMRT, IGRT, and VMAT. He's currently the director and head of the department there in the hospital in New Delhi. And Dr. Mundal has held key positions in leading institutions, including AIIMS in Delhi, Tata Memorial Hospitals, amongst many others in India. He's also a member of several esteemed professional organizations. He's received many numerous prestigious accolades, and it's a pleasure to have him here on the panel discussion. The other person on the panel discussion is Professor Savino Cilla. He's the head of medical physics unit in Italy in Campobasso Research Hospital. He's a senior medical physicist and head of medical physics there. He holds professional qualifications such as professor in applied physics, and he also serves as the adjunct professor at the Faculty of Medicine and Surgery in another part of Rome. He's authored many peer-reviewed journals over the years, and he has over 500 presentations at numerous conferences, both national and international. Unfortunately, he's had to he couldn't attend today due to some unforeseen circumstance, and so Dr. Doddle will take the lead for this panel discussion, and I will hand it over to Jubairo to set that panel discussion off. Thank you, Jubairo.
Thank you, Dr. Khalid, and thank you, Dr. Zubair, for this kind invitation and for introducing to this GAMPER. It's a real pleasure to be part of this and seeing the great audience and the participation. I believe that GAMPER will definitely do a good job in the field of academics and research. So, a great talk, Dr. Collins, on hypofractionation, radiobiology, and it was reminding me of my days of residency when we used to read the radiobiological aspects of fractionation. So literally, you have discussed almost everything: normal fractionation, hypofractionation, hyperfractionation, accelerated fractionation, continuous fractionation, and their clinical implication in terms of tumor control and normal tissue toxicity. So a great discussion, and you have also briefly touched about radiosurgery and SBRT. I think it's a very thoughtful discussion to understand from you the difference in the concept of radiobiology and tumor cell damage and normal tissue sparing when we are doing SBRT or single fraction SRS. Like in AVM, we are giving 20 gray, 24 gray, 22 gray, or 18 gray. In metastatic disease of brain, we are giving somewhere between 18 to 24 gray, depending on the volume. Or we are using fractionated SRS, and in lungs, we are giving for small tumors 34 gray in single fraction. And we are using different dose fractionation scheme depending on where is the tumor located, ultracentral, central, peripheral. So what is your take on these differences of radiobiological concepts in choosing dose fractionation?
Well, as I explained, we've tried many different fractionation schemes over the years. Very rarely have they really been successful, and they've been abandoned because they're inconvenient. Maybe the acute reactions are too much, and we had to, for instance, the accelerated fractionation, we had to give a 2-week rest period in the middle of that course of therapy. We negated the advantage. It turns out with highly conformal therapy, which we have nowadays, we've had for the last 25 years with multi-leaf collimators and so on, with an IMRT, and it's getting better and better, as you know. We're getting better at conforming the radiotherapy and avoiding irradiating the normal tissues. So personally, I think that I wouldn't be at all surprised if the vast majority of our treatments were down to about 10 gray per fraction over the next 5 or 10 years. Not 10 gray, 10 total fractions over the next 5 or 10 years. It's so much more convenient and so much less expensive to do that.
Great. It's very interesting and intriguing. I'd be very interested to know about your understanding on the very upcoming flash therapy. That is perhaps something which is going to change our clinical practice. Where do you put flash therapy in terms of radiobiology and their clinical application? And as of now, what I understand, um, all the centers across the world are actually in learning phase and research phase. There are very limited clinical data, and mostly they're skin cancers, where we have definitely seen excellent response. So, what do you think? Where the future is leading?
Well, I'm laughing because nobody knows. We don't know the answer. What something very interesting. One of my ex-colleagues sent me an email about 5 years ago, and he says, "Colin, do you know you used to do flashlight radiotherapy when you were doing your PhD?" And I said, "No, I don't. We didn't. I don't remember it." It turned out that our radiobiology group in my department where I was doing my PhD wanted to try very, very high dose rates. And it turned out we had an accelerator that we were developing for radiotherapy, the first high energy LINAC in the UK. We were 15 million volt LINAC. We were developing, and much of my research was doing the dosimetry on developing that to move it to the hospital to start treating cancer patients. We could give 1 million rads in 10 seconds. So we were actually doing flash treatments of cells. We never thought at the time that this would be better for tumors than it would be for normal tissues, which is what now it turns out by doing flash radiotherapy in concept right now. We haven't yet proven it in clinical trials, but we're going to have to work on that you can get more repair, less effect on the late reacting normal tissue cells than you do on the cancer cells. So you can save, if you like, the normal tissue damage and go to higher doses to the tumors. So I think it's interesting that I was involved at the beginning without realizing it.
That's great. That's great.
They found my name on the paper saying, "Thank you for doing the dosimetry for us."
So probably
So I think it's
on its own.
interesting.
So don't you think that history repeats on your own? Like we see this for Flash, you started a long time back, and now Flash is getting its all the flashlight on it. Like we
Yeah.
are also seeing which happens with immunotherapy in clinical oncology practice. So immunotherapy came into clinical practice somewhere in 1970s, and very quickly it went out of practice because the science did not support it that time to explore its clinical utility. And now back to 2010 onwards, we are seeing a plethora of immunotherapeutic medicines, which is actually changing the entire cancer treatment landscape. So I believe even flash therapy has that potential. What is your opinion on this?
I think there's a lot of potential. I'm waiting to see the results. I want to see the results on patients. Sure, it works on animals, it works on cells. I want to see the results, and they're coming. And people are doing it, and they're coming. But I think it's still 5 years off before we'll know for sure that flash is a great new way of treating cancer. And then physicists are going to be really involved because we've got to be absolutely sure we've got the dose right. Our job as in quality assurance is going to be far more important than it ever has been before.
One more interesting question, which I think may be interesting to the audiences as well. Like, in proton therapy, when we talk about the differential radiobiological equivalent from its entry point and exit at the or the end of the treatment or the end of the path. So there is definitely a difference in radiobiological equivalence. So although we consider it's like 1.1, we know that at the point of entry, it may be less. And when it is dumping all its energy, that RBE can be as high as 1.4. So can you please enlighten us and our audience on how this changing radiobiology can also have potential implication in terms of normal tissue toxicity? So that the proton is not about all glory if not implemented meticulously.
Well, the big advantage of one of the big advantages of protons, of course, is not radiobiological effectiveness, it's conformation of radiotherapy. You can get much more conformal dose distribution, much less dose to the surrounding normal tissues if you use protons. Unfortunately, they're very expensive. Otherwise, I think we'd all be using proton therapy for the dose distributions. In terms of radiobiology, there is a small radiobiological advantage, but it's small. If you're treating very small lesions, you can treat with the Bragg peak. If you're treating larger lesions, you have to spread out the Bragg peak. When you spread out the Bragg peak, you're spreading out high LET and low LET components, and it dilutes the RBE effect. So instead of an RBE of 1.4, which you might get for a small lesion in the eye, for instance,
Right.
you're treating ocular melanoma.
Yes.
You're not getting that with a larger field because you've had to spread out you've had to dilute your RBE. You've diluted your LET of the radiation.
Correct. To the organizers, can we please know how much time do we have, and do we take the questions from the chat box as well?
Thanks, Dr. Doddle. I was just about to take over. Thank you very much. I think we'll have to end the panel discussion there and move on to the Q&A session. Thank you very much for that, both Colin and Dr. Doddle. I liked how you guys touched on flash radiotherapy, and of course, things like spatially fractionated radiotherapy are coming back on the scene now, as you probably may know, Colin, both in protons and photons, given flash as it's kind of a fancier, hotter big brother. Thank you. So lots of things happening in the radiobiology world as time is going on. Jubail, I'm going to hand it over to you to show us the questions that you've collated together, and hopefully Colin can help answer those. Thank you.
Thank you. I'd like to request Mr. Abu Kausar, please proceed.
Yeah, there are a lot of questions in the chat box. We have selected few of them. Can you see the screen, Professor Colin?
No.
Blank. It's blank at the moment, Kausar Bhai.
Can you see, please?
No. At first, open the PPT.
Yes, I opened it.
Then share and select.
Yes.
Okay.
There you go. We have that there now.
Okay. So can you see now?
Yes.
Yeah, there's a lot of questions, but we have selected few of them. Yeah. These are the questions that we selected. So we can go for one by one. The first question,
sorry for interruption. Could you slideshow?
Yeah. It's not okay. Can you see it?
Yeah, I can read them.
Yes.
Why a gap of 6 hours is mandatory? It's not. It's at least 6 hours. So 8 hours. If you want to send the patient home and come back again 8 hours later, that will be fine. 10 hours would be fine. But less than 6 hours is a problem. And you've really got to look out for complications if you're going to allow less than 6 hours between fractions. It probably varies between different types of normal tissues. I don't know the answer to that. That's going to be part of the studies that are being done of clinical data. So probably 6 hours between fractions is a reasonable minimum. Is the window of opportunity applicable to other procedures? Certainly brachytherapy. low doses per fraction are going to be better. And by the way, high dose rate brachytherapy, more fractions, the more conformal the radiotherapy you can make it. And of course, brachytherapy is very conformal. You're putting the radiation inside the cancer in brachytherapy. So that certainly applies to brachytherapy. And I'm sure it applies to proton therapy as well. Oh, compensation for gaps. That's an interesting question. How do you compensate for gaps in radiotherapy? The way I would do it is, if I use the LQ model, I would use I would first of all ask the radiation oncologist for this particular patient, is this a rapidly growing cancer or a slow growing cancer, whatever? And I'd use the appropriate K value in the calculation to determine the effect of radiation gaps for a given patient. The radiation oncologists used to have a rule of thumb, which applies to conventional fractionation, but it won't necessarily apply to things like hypofractionation. They had a rule of thumb for every 2 weeks of a gap, you add 1 extra treatment. And it's interesting, the LQ model pretty much predicts that for conventional fractionation, which is what they were using at the time. Can we give more than 5 fractions per week for head and neck cancer patients? Maybe that's talking more about doing 7 days a week. We did that in our practice. We went to 7 days a week. We didn't see any particular advantage of doing that, and we dropped it because the staff didn't like it. They didn't like coming in at weekends. They like to have their rest at weekends. Cancer cells, I'm not sure. The only way we can stop cancer cells from growing is to eradicate all the cancer cells. So we have to get rid of all the cancer cells to stop them growing. Just leave 1 or 2 cancer cells behind, and eventually that will cause a recurrence. And of course, we're very careful not to do that in surgery. The surgeons try not to do that. They apply chemotherapy to the patients in case there are a few cancer cells left over. Maybe they weren't in the area that you tried to remove them. They were outside the periphery of the tumor that you tried to remove. And maybe they're outside of the periphery of the high dose region that we're trying to treat with radiation. So that would be a real problem with cancer cells. Okay. Well, why did 5 fractions per treatment in rectal cancers show increased local recurrence than conventional fractionation? Probably because you didn't go to a high enough dose. 5 fractions of 5 gray isn't enough total dose. You need to go to a more fractionated scheme. Probably 2 gray per fraction in 30 fractions would have been considerably better, and you get less recurrence. Very good question about the application of the linear quadratic model to SRS, SBRT schemes, hypofractionation. Let me talk about the linear quadratic model. It's an approximation. It's the best that we've got, but it's an approximation. Ultimately, we need something better. A famous statistician by the name of Box said that all models are wrong, but some are useful. And I consider the LQ model to be a useful model to demonstrate the effects of things like fractionation, and the LQ model can be used for brachytherapy as well. But don't rely on it as being accurate, especially with outside of where it was first developed. It was first developed on data from about 2 gray per fraction over many decades of treatment. But now we're starting to go to higher doses per fraction. We need to take a really close look at the LQ model, see if we can develop a better model. And a lot of people are doing that. I bet you there are dozens of PhD students worldwide studying this, looking at clinical data that's been published over the years, like the Quantec data that we started collecting 20 years ago, taking a look at that data and coming up with a better fit of a model to things like hypofractionated treatments. But right now it's the best that we have, so we're using it. But don't absolutely rely on the numbers that you get coming out of that data. They're a good indication of what you might be getting, but it's definitely not an accurate model. It's way too simple for all the complicated things that are going on inside a cell when you're irradiating it. So many things are happening other than just simple repair. Lots of other things are happening. And you've got to take into account, we didn't even talk about it, things like oxygenation of the cells and how that changes during a course of radiotherapy. We never even mentioned that, but many people have brought oxygenation into the LQ model. Makes it much more complicated, and eventually we might start using things like that. And artificial intelligence is going to play a big role in when we look at fractionation in radiotherapy and the best fractionation schemes to use for different kinds of cancers and within different types of normal tissues. So I suspect that AI is going to maybe take over biological models like the linear quadratic model within the next 10 years. I think I've answered most of the questions.
Dr. Colin, would you mind if I want to add a little bit about the Rapido trial?
Yes.
So the reality is the tolerance of Rapido or the serious adverse events in the Rapido trial was not less in the experimental arm, which used 5 gray times 5 days. If you see the data, the serious adverse events happened in almost 40% of patients in the experimental arm, which was 5 gray times 5. And it happened in almost 35% of the patients in the standard arm, which was 1.8 gray to 2 gray per fraction. Now, what happened in Rapido is actually not about the toxicity, it's about the overall tumor-related outcomes. And if you know the inclusion criteria of Rapido, it was mostly the advanced tumor groups. So in Rapido, the advantage in terms of tumor control was probably not because of the radiation itself, but introducing chemotherapy early in the course of rectal cancer treatment for such highly advanced tumors, which probably would have caused systemic metastasis in case systemic therapy was delayed. So the benefit coming from Rapido trial is actually a fact of when you are playing with different treatment strategies and their timing in the course of treatment. So in Rapido, you are giving radiation, then you are giving chemotherapy, and you are doing delayed surgery. So that gives you enough time to control micrometastatic or systemic disease, which was undetected. And in the standard arm, you are treating with radiation first, then you are doing surgery, and then you're doing adjuvant chemo. So the systemic therapy is significantly delayed in the standard arm. So that's the basic difference in Rapido trial. Thank you.
So thank you very much for the wonderful discussion and answer of the question. Now we have a next wonderful announcement for our next webinar, which is going to be held on the next month. So can you share?
Yes, we can.
Yes, please proceed.
As we come to the conclusion of today's session, I would like to extend my heartfelt thanks to all those who made this event successful, to our distinguished speaker, our panel of experts, and most importantly, to our global participants. Thank you for your active engagement. And please note that the recording of this session and the certificate of the presentation participation will send to all registered attendees in the coming days. We also please to announce our on the next webinar on the treatment plan checks as a risk management tool, which is going to be held on 8 July 2025 with our another great speaker, Professor Dr. Thomas Krohn. So you all are welcome to attend the next webinar. And again, I would like to thanks once again for your presence and participation. Stay safe and stay motivated, and let us continue working together to improve cancer care around the world. So goodbye and take care.
Bye, everybody. Thanks
Yeah.
for inviting me.
Thank you, sir.
Bye, everyone.